All right, Dr. Pabico, I'm going to turn it over to you.
Great. Thank you so much, Lynn. Good afternoon, everyone. I'm Dr. Christine Pabico, Director of ANCC's Pathway to Excellence program. I am delighted to welcome all of you to Policy Dialogue for the Future of Nursing Home Quality, a panel discussion on the National Academies of Sciences, Engineering, and Medicine's recently released report, The Quality of Care in Nursing Homes. This report examines how our nation delivers, regulates, finances, and measures quality of nursing home care, including the long-standing challenges brought to light by the COVID-19 pandemic. And being highlighted in today's presentations are the challenges for nursing. I'm extremely grateful to Dr. Marilyn Rance for collaborating with us at ANCC and helping us plan today's event. As Lynn said, please note that this presentation is being recorded. So in case you have colleagues that weren't able to make it to today's webinar, let them know that it'll be made available on the ANCC website. Attendees of this webinar will also have the opportunity to obtain CE, so you'll receive a follow-up email after the webinar from the Pathway Program Office with the survey. Finally, we ask that you keep yourself muted throughout the presentation and to post your questions in the chat box. One of my colleagues, Dr. Lynn Newberry, will be monitoring the questions, and at the end, we are dedicating time for our speakers to address some, if not all of your questions. It is now my distinct pleasure to introduce our distinguished panel of experts that are all part of NASEM's community and committee and staff. First is Dr. Marilyn Rance. Dr. Rance is the Curator's Professor Emerita of Nursing at the MU Sinclair School of Nursing. Dr. Rance's work focuses on measuring effectiveness of nursing care coordination, exploring new delivery models of care for older adults, and technology development to enhance aging in place of community dwelling elders. Dr. Rance is an international expert in quality measurement in nursing homes and has been a member of the National Academies of Science, Engineering, and Medicine since 2012. We also have Dr. Greg Alexander, who is the Helen Young Alumni Association Professor at Columbia Nursing. Dr. Alexander has a broad background in human factors, informatics, gerontology, patient safety, and quality improvement. And then finally, Dr. Tracy Lustig is a Senior Program Officer with the National Academies of Sciences, Engineering, and Medicine. Dr. Lustig was trained in podiatric medicine and surgery and spent several years in private practice. Dr. Lustig was the co-study director for the study on the quality of nursing home care. I'm now going to hand it off to Dr. Lustig, who will give an overview of the core recommendations from the report.
Hello, everyone. Thanks for being with us today. As was just mentioned, I'm Tracy Lustig, and I'm one of the staff co-leads for the study on the quality of care in nursing homes that authored the study we're going to be talking about today. On behalf of the committee and the National Academies, of course, I want to express our gratitude to our sponsors who supported this tremendously important work. And of course, I'm glad that my colleagues from the committee, as you heard, Marilyn Rance and Greg Alexander are with us today. And we're really pleased to represent the full 17-member volunteer committee who brought expertise from a wide range of disciplines and backgrounds. Before we get started, I do want to explain that the deliberations of the committee are confidential. And so while we can clarify what was meant by certain statements in the report, the Academy's process does preclude any insight into specific committee discussions. Today, we're planning to give a brief presentation of the report and the final recommendations, and then we'll open the meeting for discussion and to answer your questions. So first of all, we always like to start by noting that nursing homes play a unique role in our nation's long-term care continuum. They serve as a place both where people receive needed health care, as well as a place they call home. Although long-term care is increasingly being provided in home and community-based settings, nursing homes will likely always be needed for individuals who cannot get the level of care they require in those other settings. The 1986 Institute of Medicine report, Improving the Quality of Care in Nursing Homes, described numerous concerns, and OBRA 87 subsequently established more stringent standards and regulations. While many improvements have been made over the intervening 35 years, the enormous toll that the COVID-19 pandemic had on nursing home residents, their families, and staff has brought renewed and heightened attention to the longstanding shortfalls that continue to plague nursing homes. As noted by a caregiver who wrote to this committee, the pandemic has lifted the veil on what has been an invisible social ill for decades. So now I'm going to go over our charge and approach to this study. In brief, the committee's statement of task was first to examine how our nation delivers, regulates, finances, and measures the quality of nursing home care. Second, the committee was asked to develop a set of findings and recommendations to delineate a framework and general principles for improving the quality of care in today's nursing homes. Finally, while the COVID-19 pandemic was not the main focus of this study, we were asked to pay particular attention to the challenges that have arisen in light of the pandemic. Over the last year and a half, the committee had 5 committee meetings, multiple additional small group calls, and 6 public information gathering sessions. We also collected narratives from residents, families, and staff that you'll see interspersed throughout this presentation. We also performed literature reviews, and we had 16 external experts review the report before it was released. The committee ultimately came to 7 overarching conclusions. First, the way in which the United States finances, delivers, and regulates care in nursing home settings is ineffective, inefficient, fragmented, and unsustainable. Second, immediate action to initiate fundamental change is necessary. Even prior to the pandemic, nursing home care was neither consistently comprehensive nor of high quality, and regulations in place for 35 years have not been fully enforced. Third, all stakeholders need to make clear a shared commitment to the care of nursing home residents. Fully realizing the committee's vision will depend upon the collaboration of multiple partners. Fourth, extreme care needs to be taken to ensure that quality improvement initiatives do not exacerbate disparities in resource allocation, quality of care, or resident outcomes. Fifth, high quality research is needed to advance the quality of care in nursing homes. Limited evidence in several areas presents challenges to determining the best approaches to improving quality of care. Sixth, the nursing home sector has suffered for many decades from both underinvestment in ensuring the quality of care and a lack of accountability for how resources are allocated. Finally, all relevant federal agencies need to be granted the authority and resources from the U.S. Congress to implement the recommendations of the report. I'll now hand it over to Marilyn Rance, who will explain our conceptual model and committee's vision.
Thank you, Tracy. It's a pleasure to be here today. As a framework for this study, the committee created an original conceptual framework of high quality care, which is fully described in the report. I'd like to point out that we recognize that many inputs go into making a good quality nursing home for residents, such as oversight and regulation, payment and financing, and the surrounding community, just to name a few. Key to the model is the central focus on residents. For good quality of care, residents must be the central focus of the organization. And you can see how outcomes result from the care residents receive and a strong quality improvement focus to continually improve the quality of care. This model that we developed guided all of our work. Secondly, next slide. The model depicts the committee's vision of nursing home quality, which residents of nursing homes receive in a safe environment that honors their values and preferences, addresses the goals of care, promotes equity, that's extremely important, as all of these are, and assesses the benefits and risks of care and treatments. That overall vision is what we attempted to address when we developed all of these goals and recommendations. Improving the quality of care in nursing homes is not only possible, but represents a critical societal and public health imperative. Though the recommendations focus on diverse areas for improvement, they all share an underlying premise. The challenge facing nursing homes are complex and multifaceted and require immediate attention on multiple fronts by many stakeholders. Finally, the committee emphasizes the vital importance of attention to health equity, which is woven throughout its recommendations. Now our overview to the committee's extensive recommendations that fall into 7 critical goals. We've also highlighted challenges for nursing in red throughout the slides, so pay attention to those. I'll hand off to my colleague, Greg, who will present the first 2 goals.
Thank you, Marilyn, and thank you for having us today. The committee's first goal is to deliver comprehensive, person-centered, equitable care that ensures health, quality of life, and safety, promotes autonomy, and manages risk. While person-centered care is foundational to the basic requirements specified in existing federal regulations, such care is not yet a reality for many nursing home residents. A focus on care delivery that respects the residents' voice and diversity, care that is equitable and strives for the best and most attainable quality of life for residents and their significant others, and care that truly balances resident wishes and autonomy while assuring safety is the standard for nursing homes, government, and the broader community to work together to achieve. This standard requires the development of stronger connections between nursing homes, their communities, and government support. The first goal has several challenges for nursing, including a needed action in nursing education and practice to focus and take responsibility for leading care planning in nursing homes. Their leadership is to role model and provide person-centered care, assuring every resident's preferences are honored, as well as their individual needs are addressed and their goals of care. Nurses need to be educated about and educate others about equitable care and detailed safety preparedness. We need to demonstrate to the public that we are making sure the terrible events of the COVID pandemic in nursing homes are never again repeated. Critical gaps in the quality of care exist in areas ranging from the development of comprehensive care plans for each resident, including who is part of developing the comprehensive plan, such as certified nurses aides, qualified nurses and social workers, families, and the residents themselves, and what is included in the comprehensive care plan. The committee recommends a number of actions to address these shortcomings. First, the committee calls for immediate and consistent compliance with existing regulations for care planning, putting this intent into action with recommendations for registered nurses to provide this oversight and for all members of the interdisciplinary team to contribute to the care plan. Care plans should include resident preferences, and preferences should be obtained regularly and systematically, including the input of residents. The care plan should focus on medical care needs and emphasize psychosocial, cultural, spiritual, and behavioral care, as well as physical care. Second, evidence on best practices for the provision of a broad array of services is scarce. The committee recommends research and demonstration projects on effective and innovative models of care. We need to test optimal models where residents are able to thrive, disparities are reduced, staffing is ideal, technology is used to enhance care, and leadership is strengthened and supported. This presents a challenge for nursing research. Third, even before COVID-19, nursing homes were largely unprepared to respond to emergencies and natural disasters. The committee provides recommendations to strengthen nursing home preparedness to protect residents and staff, and to emphasize their inclusion and preparation in public health responses. Finally, given the vital role of the physical environment to quality of life, the committee has several recommendations to create smaller, more home-like settings of care that support more opportunities for social connection and engagement, stronger infection control practices, and connections to clinical staff, such as through open kitchens, therapeutic outdoor areas in all nursing homes, socialization spaces, or shorter corridors. The committee's second goal is to ensure a well-prepared, empowered, and appropriately compensated workforce. It is time for this workforce to be appropriately compensated. We recognize and honor those devoted staff who care for our vulnerable nursing home residents every day and who were there at their sides during the COVID-19 pandemic. Our recommendations are designed to help them continue their service and thrive in a better working environment. ANCC's Pathway to Excellence framework for creating positive practice environments is an example of a blueprint nursing homes can use to ensure the workforce has a voice, that they feel empowered, that they're valued, are well prepared, and work in an environment where they feel supported. So why is it important to improve the work environment? Workers in nursing homes, many who are nurses and nursing assistants, are often underappreciated, undercompensated, and underprepared for the roles in providing increasingly complex care of residents. Decades of evidence support the need to enhance their training services or their training salaries and working conditions, yet little progress has been made to improve the quality of these jobs. The committee recommends increasing both the numbers and the qualifications of virtually all types of nursing home workers. This may be concerning given the dire staffing situations for many nursing homes. However, robust evidence demonstrates the positive impact of enhanced staffing and training requirements on the quality of care. Enhanced requirements will further professionalize the nursing home workforce, which, when accompanied by improvements in the work environment, will contribute to the desirability of working in a nursing home. For successfully recruiting and retaining a high-quality workforce depends on more than adequate compensation. Rather, the committee calls for ensuring competitive wages and benefits, including health insurance, childcare, and sick pay for all nursing home workers. Next, the committee calls for the immediate implementation of higher staffing standards in nursing homes. For example, 3 previous studies of the ION, the Institute of Medicine, recommended the 24-hour presence of registered nurses, yet this has not been made a requirement. Even more concerning, the same federal staffing regulations have been in place for decades, even though the types of residents and the complexity of their needs have changed dramatically over the years. The committee recommends research on minimal and optimal staffing standards for all direct care staff, meaning nurses, therapists, social workers, updating regulatory requirements based on this research, and strategies for acquiring additional expertise for advanced care needs. Given the role of the certified nurse assistants in providing the majority of hands-on care to the residents, the committee provides recommendations for empowering this workforce, including career advancement, peer mentoring, free entry-level training and continuing education, role expansion, and new models of care that include those disciplines. Education and training requirements for a variety of staff are inadequate or non-existent. The committee recommends minimum education and competency requirements to be made standard nationally. Beyond these baseline requirements, the committee calls for annual continuing education, ongoing diversity, equity, and inclusion training for all staff, including leadership, and resources and training for family caregivers so they are included as part of the caregiving team. This is important to truly transform the working condition and environments. A greater number of professionals, such as APRNs, who are professionally prepared social workers also, physicians, and others need to be involved in nursing home care. Yet data are limited on these types of workers, including their numbers and the extent of their training and expertise in nursing homes specifically. The committee recommends the collection and reporting of such data, including for contract and agency staff. Finally, more information is needed regarding systematic barriers and opportunities for recruitment and training and advancement, as well as for job quality indicators such as job satisfaction and turnover. There are key challenges in these recommendations for nursing education and practice, including the hiring of licensed clinical social workers for all nursing homes, as well as increasing the numbers of APRNs working in them too. better preparing directors of nursing so that all have a baseline education of BSN with an MSN preferred. These will be challenging for nursing education to be sure we have the supply of educated professional nurses to work in nursing homes. They also need geriatric specific education and infection prevention training. It is imperative that all healthcare professional programs have educational content related to gerontology, geriatric assessment, long-term care, and palliative care. Clinical experiences need to include experiences in nursing homes, and there is ongoing needs for annual education of all nursing home staff and leadership, particularly regarding diversity and inclusion and family caregiving educational resources. I'd like now to turn it back to my colleague Marilyn, who's going to discuss recommendations related to the next 4 goals. Marilyn. Marilyn, I believe you're muted.
Thank you, Greg. Oh dear. Our committee would like to point out that all 7 goals fit together and form a roadmap to implementation to improve care in nursing homes. They're not meant to be pick and choose the ones you like, but are intended to complement each other and together provide that integrated roadmap to finally improving nursing home care. I'll provide an overview of the next 4 goals. The committee's 3rd goal is to increase the transparency and accountability of finances, operations, and ownership. A key barrier to effective nursing home oversight has been lack of transparency regarding nursing home finances, operations, and ownership. CMS makes some ownership information available, but these data are incomplete, often difficult to use, and do not allow for assessment of quality across facilities owned or operated by the same entity. Moreover, there's little transparency regarding the practice of some nursing homes to contract with related party organizations that are also owned by the nursing home owner and provide services such as management, nursing, or therapy. Increased transparency and accountability are needed to more fully evaluate how Medicare and Medicaid payments are spent and how ownership models and spending patterns impact the quality of care. The committee recommends collecting, auditing, and making detailed facility level data on finances, operation, and ownership of all nursing homes publicly available in real time in a readily usable database that allows for the assessment of quality by common owner or management company. This presents a challenge for nursing research. The committee's 4th goal is to create a more robust and a rational and robust financing system. The current approach to financing nursing home care is highly fragmented. The federal state Medicaid program plays a dominant role as a payer of long-term nursing home care, but is constantly subject to state budget constraints. The federal Medicare program not only covers short stay, post-acute care in nursing homes. The services such as hospice care are paid separately by Medicare and are not well integrated into standard nursing home care. Private insurance company coverage for long-term care is limited, and relatively few people can afford to pay out of pocket for an extended nursing home stay. In an effort to create a more rational approach to financing nursing home care that would address these significant shortcomings, the report includes a recommendation about moving forward toward a federal long-term care benefit by studying how to design such a benefit, then implementing state demonstration programs to test the model prior to national implementation. Our current system is ineffective, inefficient, fragmented, and unsustainable. The fragmented financing system leads nursing homes to rely on higher payments from Medicare services to cross-subsidize lower Medicaid payments, an inefficient and unsustainable arrangement. In general, states are required by law to provide assurances or sometimes evidence that Medicaid payments are adequate to provide access to high-quality care. Not in all. Nursing home payment rates, however, are not subject to that requirement of adequacy. To ensure adequate investment in caring for long-stay nursing home residents, the committee recommends the use of detailed and accurate financial information to ensure payments are adequate to cover comprehensive nursing home care. The committee also recommends designation of a specific percentage of Medicare and Medicaid payments for direct care services, as opposed to non-direct care costs, such as lease payments. The short stay post-acute nursing home care, the committee calls for extending the current bundled payment arrangements to all conditions in an effort to advance value-based payment based on quality, not quantity of service. Additionally, the committee recommends demonstration projects to explore the use of alternative payment models for long-term care, nursing home care, the separate from the bundled payment initiatives for short stay post-acute. These demonstrations, again, present challenges for nursing research, and we need to help guide those projects. The committee's fifth goal is to design a more effective and responsive system of quality improvement and assurance. Although federal oversight standards and processes are uniform across states, considerable variation exists in the implementation of routine inspections, in the imposition of sanctions, and in the investigation of complaints. The survey process often fails to identify serious care problems, to fully correct and prevent the reoccurrence of those problems, and to investigate complaints in a timely manner. Currently, CMS does not provide sufficient oversight of or transparency in the survey process. The committee provides recommendations to ensure state survey agencies have adequate resources for the oversight of state survey performance. Despite the prominent role of nursing home oversight and regulation, the evidence base for its effectiveness ensuring the minimum standard of quality is relatively modest. The regulatory model needs significant improvement, but there is little consensus or evidence to suggest which approaches would ultimately lead to improvement in quality of care. The committee recommends developing and evaluating strategies to improve quality assurance activities. The committee provides several other recommendations related to quality assurance, including increasing funding of the Long-Term Care Ombudsman Program and its collaboration with other state-based entities, denying licensure and imposing enforcement actions on owners with a pattern of poor quality across facilities and across states, and the elimination of certificate of need regulation and construction moratoria. Goal 6. To improve quality of care, specifically, the committee's sixth goal is to expand and enhance quality measurement and continuous quality improvement. I'd like to stop at this point and say that all of these recommendations are based in evidence. They are not just our opinions. These are based in evidence, the best science available at this time. We reviewed all of that science. It is essential that we solicit directly from residents and families their perspective and experiences receiving care in the nursing home. The committee recommends that the CHAPS measures be systematically collected and reported. Similarly, experience measures of care in other healthcare settings have been collected and reported for years. It's time for the experience of nursing home residents to also be reported. The CMS website, Care Compare, provides data on the quality of care in nursing homes. However, many key indicators of high quality care are missing, and several improvements are needed to enhance the quality of the reported data. The committee recommends adding several measures to Care Compare, including the CHAPS measures of resident and family experience. The committee also recommends facilitating the ability to examine performance across facilities and across state lines with common ownership or management, improving validity and improving differentiation in the 5-star composite rating. Additionally, more work is needed to develop valid measures for key domains of quality, including palliative and end-of-life care, staff satisfaction, psychosocial and behavioral health, and other structural measures. The quality of nursing home care is particularly concerning for several high-risk populations who experience disparities in care. However, the lack of robust data makes it difficult to document the true extent and impact of disparities in care. The committee recommends the development of an overall health equity strategy for nursing homes, which includes a minimum data set, a national report card, culturally tailored interventions and policies, and strategies to identify and address disparities. The tragic disproportionate results for people of color dying in nursing homes during COVID pandemic cannot be allowed to ever reoccur. Finally, many facilities lack adequate expertise and resources for effective quality improvement. The committee recommends the development of technical assistance programs at the state or even local level by individuals who are most familiar with the nursing home's specific community and challenges, who have specific expertise in nursing home quality, and who have consistent and ongoing focus on nursing homes. The challenges for nursing education and research include research focused on quality performance of facilities of common ownership across states, currently not available. But with these recommended changes, there will be that ability. Additional testing of existing quality measures and development of new measures, including measures of diversity. The perspectives of nursing is essential for research as well as education of nurses about these measures in nursing homes. There's also another opportunity where nursing is well positioned to work with other professional disciplines to develop statewide technical assistance programs to improve the quality of care in nursing homes by directly working with nursing home staff. Missouri has such a program, and it has had that for more than 20 years. Sponsored by our leading nursing program in the state and serving our over 500 plus nursing homes every day with on-site technical assistance, evidence-based practice guidance, and quality improvement education and assistance for all nursing home staff. Others can duplicate and improve upon this work. I will hand off once again to my colleague, Greg Alexander, an expert in health information technology, for our final goal.
Thank you, Marilyn. So closely linked to quality improvement and improved quality of care is the committee's 7th and final goal, to adopt health information technology, or HIT, in all nursing homes. Health information technology can contribute to personalizing the care interventions of resident needs and desires in an efficient and accurate way. Nurses can specify individualized plans of direct care so that nursing assistants can assure approaches to each person are what they not only want, but what they need. HIT increases efficiency in care delivery, enhances care coordination, improves staff productivity, promotes patient safety, and reduces health disparities. Residents often have complex conditions that require care coordination across multiple care settings, further underscoring the need for nursing homes to have electronic health records that communicate with other systems to ensure smooth, accurate transfer of clinical information and safe care transitions. While previous federal programs provided incentives to certain healthcare professionals and hospitals to support EHR adoption, nursing homes were not eligible for such incentives. The committee recommends identifying pathways to provide financial incentives to nursing homes for adoption of certified electronic health records. During the COVID-19 pandemic, those nursing homes using health IT applications had access to critical means of communication when lockdowns led to limited access to in-person clinical visits and resident isolation from friends and family members. Can you imagine how much better the experiences of isolation, loneliness, and dying with no family members to comfort you in your last days or hours could have been if all nursing homes had health IT like other healthcare settings? How much better the clinical care could be if all nursing home leaders and direct care staff have the information that can be readily compiled and easily reported for important health events like falls or urinary tract infections or upper respiratory infections or skin breakdowns, to name a few. Armed with real-time information about these health events, leaders can work with direct care staff to isolate underlying environmental or care conditions that, if remedied rapidly, resolve the underlying causes and result in better health outcomes and qualities of life for residents. That is real-time quality improvement facilitated by HIT. The committee also recommends the development and reporting of baseline measures of HIT adoption and interoperability. Interoperability is the ability to communicate with other electronic health records. Moreover, it is vital to understand the various barriers and facilitators to HIT use in nursing homes in order to improve the efficiency, effectiveness of, and satisfaction with HIT for staff, as well as residents and their families. As nursing homes adopt HIT, training of nursing home leadership and staff in core health information technology competencies is needed. Finally, ongoing evaluation studies are needed to assess the impact of HIT on resident outcomes, to examine innovative uses of HIT, and to understand disparities in HIT adoption and use across nursing homes. These recommendations provide more challenges to nursing education, such as workforce education and training, emphasizing core HIT competencies for nursing home leadership and staff, telehealth, and interoperability. There are challenges for research that include evaluations of use of HIT to improve resident outcomes, disparities in adoption of HIT, innovative HIT applications for resident care, assessment of clinician, resident, and family perceptions of HIT usability. Some final thoughts in closing. We obviously have only given a very broad overview of the report here today, but I would like to emphasize that there's an incredible amount of detail in the report itself. I would encourage you to pay particular attention to Chapter 10, which provides a deep dive into the context and specifics of the recommendations that we have only briefly touched on today. The time to act is now. The need to reform how care is financed, delivered, and regulated in nursing home settings is urgent and it's undeniable. Failure to act will guarantee the contribution and continuation of many shortcomings that prevent the delivery of high quality care in all nursing homes and pose a threat to residents' health and safety. The COVID-19 pandemic provided powerful evidence of the deleterious impact of inaction and inattention to longstanding quality problems on residents, families, and staff. At the same time, however, the pandemic served as an opportunity for change to drive critically important and urgently needed innovations. Implementing the committee's integrated set of recommendations will move the nation closer to making high quality, person-centered, and equitable care a reality for nursing home residents. It's been 35 years since the passage of OBRA 87 and landmark nursing home reform measures. It is of the utmost importance that all nursing home partners work together to ensure that residents, their families, and staff will no longer have to wait for needed improvements for the quality of care in nursing homes. Again, we believe the time to act is now. It is clear there is an alignment between the ANC. Oh, I'm going to turn it over to Tracy. Sorry about that. This is Tracy's work.
Thanks, Greg. As Greg was saying, it's clear there's some alignment between the ANCC's work and this report, particularly in fostering interprofessional collaboration, empowering engagement that supports team-based care to meet and exceed established quality standards, Implementing the ANCC programs with the recommendations presented today, we hope will lead to the improvement of quality of care in nursing homes. We thank all of you for your attention, and we're now going to open up for discussion and invite your questions. Turning over to Lynn.
Great, thank you, Tracy. So there are several questions that have been posed in the chat. So I'm going to go ahead and read the first one available here. This is from Tia Sheck. In reference of goal number 4, what impact do you anticipate on the acute care setting with changes in payment models in nursing homes?
Well,
Anyone from the team like to take that?
I was going to start off and say, to some degree, that that's why we're not saying to go ahead and just start doing it and implement this as federal law. Many of our recommendations around the different payment models are calling for demonstration programs. We often, I think, sometimes Academy's reports are criticized for research calling for more research, but one thing that the committee was very aware of was not wanting to cause unintended consequences. Major change, the phrase we've used a lot is being boldly pragmatic. And so we have to start where we are and start learning from it. But we know that what's happening now just isn't working.
I would like to say that I think there could be some spillover effects in acute care. But again, as Tracy said, we need to be careful in the implementation to make sure that the spillover effects are anticipated and planned for if there are any spillovers to acute care. It was not our charge to develop strategies that would affect acute care. Our strategies are focused, and the financing of long-term care is very different from acute care. So I would anticipate, at least initially, there may be some unintended consequences that we deal with later, but initially, I don't anticipate impacting or prompting a huge change in acute care. But I don't have a crystal ball.
Yeah, I would, I want to sort of mention also, I noticed Ms. Sheck also mentioned something about health information technology in the chat. And so I've worked over several years on a national demonstration project in nursing homes in Missouri that looks specifically at how to avoid potentially avoidable hospitalizations and how to reduce those and keep people in the nursing homes. And I want to say that the 16 nursing homes that we worked in did not work in isolation to do that. It required the collaboration across all settings and all disciplines to make sure that people were treated appropriately in the right setting, and that people were managed appropriately in the right setting. So what that means is that in nursing homes, that there are opportunities for more aggressive management of people rather than transferring them. Oftentimes the transfers create real problems for people from a health standpoint. And so, but there is a need for acute care. There is a need. They have services and resources that nursing homes don't. So there has to be some collaboration because people are going to go back and forth. There's no way we can stop that. And so we're hoping that at least our recommendations improve in that collaboration and improve the integration of care delivery really in all settings, even though our charge was just in nursing homes.
Thank you. Another question it comes from Anne. Did the committee discuss revisiting the consensus model so that APNs have greater specialty expertise in gero nursing?
We spend a lot of time talking about that. And in fact, that is covered in our recommendations surrounding nursing education, so that all of nursing education has to have gerontological nursing content in that area. So there are lots of BSN programs and lots of MSN programs that do not. That needs to change. And the content in gerontological nursing needs to have more specialty education and more expertise in gerontology. That's absolutely true.
I can't help but give a plug for an earlier National Academies report that we reference in this report. So for this current report, we certainly speak broadly that all healthcare professionals need geriatrics education and training. We also cite a 2008 report from the Institute of Medicine that I hope many of you are familiar with, called Retooling for an Aging America, that I had the pleasure of also being a staff lead for, in which we do specifically call for more specialization in geriatrics by healthcare professionals such as nurses. And again, just more general education for all healthcare professionals.
Yeah, I want to also add that we looked at education broadly too. So I teach DNP students in a very large informatics course at Columbia University. It surprises me how oftentimes that, advanced practice nurses and other nurses going for graduate degrees, how sometimes they really don't know a lot about informatics, or they don't know a lot about electronic health records or health information technology and how it can be used. And COVID actually created opportunities for us to see how the training lacked, really, because they were using telehealth systems that they had never used before. They weren't aware of how to integrate them into the settings. They were just making it up as they went because there wasn't good evidence about that. And so our report really addresses those sort of opportunities to advance people's understanding of models of care that incorporate technology so that they're not just having to wing it.
Thank you. I don't see any other questions pop up in the chat. Wanted to also be able to allow anybody, if they didn't want to put something in the chat and they wanted to raise their hand, and we can open their mic so that they can ask this team their question. We have a little bit of time left for more question and answers.
While we're waiting, I do see a part of a question I'm not sure we fully answered about.
Okay, thank you.
Generational gaps when it comes to using technology. And I actually also run an ongoing forum on aging, disability, and independence, and happen to also have been the study lead for a study that came out in 2020 on social isolation and loneliness in older adults that we released in February of 2020. So interesting timing. But we certainly recognize that there may be some need for help and training older adults in using technology, but we also are careful to say that we shouldn't just assume that older adults aren't familiar with using technology. We shouldn't, in a sense, promote a potentially ageist frame. There are many adults that are older adults that are using technology well and can do that. I don't know if Greg, you have any more experience along those lines.
Well, I was going to say that both Greg and I have had a lot of experience with older adults in the community and in independent housing and in nursing homes. And it's surprising. We've been part of an elder tech research team since the early 2000s. And it's surprising to see how much more comfortable older people are now than they were when we were first poking at this problem and planning for developing new technology to help people age in place. I mean, people are far more comfortable. But there are gaps, and I see in the chat, you know, interoperability is huge, and that's something that we spend a lot of time on. And it also, we need to deal with and have the resources for people who are not comfortable, for them to be able to benefit from the use of that technology, given especially the video conferencing capability. That was absolutely essential for people to have contact with their loved ones.
I'll also add, you know, there are all sorts of new innovations coming up. We talk a lot about innovations in the report, and there's a lot of new innovations coming out that have to do with robotics and other types of technologies that nurses are just probably have not been trained well to use in the environment, and certainly patients and residents in these facilities are probably not used to interacting with social robots and those kinds of things, which actually collect data about their interactions and can tell people about outcomes like depression and ability to communicate and those and changes in condition. And so our educational models are going to have to shift as these new innovations are embedded in our care settings like they've never have been before.
Thank you. One more question here. Are there any volunteer opportunities for nursing informaticists with a great interest in helping to improve elderly care?
Well, sure, I can take that. I got involved through my professional organizations. The Midwest Nursing Research Society, MNRS, has a health policy and informatics expert group that does a lot of work in trying to do journal clubs and to support faculty and researchers as well as clinical staff in the understanding about how technology can be used in the clinical setting, and also how it affects how policy is being addressed to address that problem. I also work very closely with the American Medical Informatics Association, which has a nursing informatics working group that's very, very active in health policy and legislation, and also clinical bedside care and the use of technology. And they're very, I would encourage you to get involved in those groups, because there is an angle to those groups that helps people. The mission is to help people understand how technology can make a difference, or how it can also be a barrier in some ways. And I think there's on the next slide or so, there's something about a commission with working with ANCC. And I think those kinds of things are important to be involved in, so that you can learn a little bit about how technology, because it's pervasive, it's everywhere, so you can't really get away from it.
I would like to encourage you. Also, I see you're retired Army, and there are, pursue the opportunities that Greg explained, but also reach out to some of the aging communities that are in your community, and see what the status is of their current use of health information technology. You may be able to have a huge impact in your own community to help them implement and to better utilize what opportunities are there. And you may find there are many places. I know that there's a group within Leading Age and a group within AARP that have identified long-term care and continuing care retirement communities who are attempting to use technology in more advanced forms. So, and I'm sure that the same is to be said within homes that are part of the healthcare association and the for-profit realm. So both of those large organizations could use your help as an informaticist.
Wonderful. Well, we are about to wrap up, so I'm going to turn it over to Dr. Pabico for the closing.
Great. Thank you so much, Lynn. Sorry, I'm having trouble turning my video on, but I just want to thank all of you so much for this excellent dialogue. Great information shared by our speakers and excellent questions from our attendees. I know I'm walking away from this webinar more enlightened about our current state, recommendations for improvement, which makes all of us reinvigorated and more passionate to do more to support our nursing staff and also to improve care for our long-term care residents. To our panel, I'm hoping to be able to continue working with all of you, not only in sharing this information, but in helping put actions to the recommendations. Again, thank you so much on behalf of ANCC, and thank you to all of you who joined us today. Before we end, I do want to share with you a great opportunity to be able to contribute and also influence practice environments on a global level, including in long-term care. ANCC just posted a call for commissioners, and the Pathway Commission is the governing body that sets the standards for the Pathway to Excellence program, and it has representations from various sectors. And one of the 3 positions that are posted is specifically for long-term care. So we do think that this is a great audience for that. If this is something that you're interested in, in the chat, we are posting the link. And it's also going to be included in the follow-up email that Dr. Lynn Newberry is going to be sending for you to be able to get your CE. Also, if you have any questions about the Pathway program, we're also providing you the Pathway info box there where you can reach us. And talking about technology, we have a QR code that, if you wish to scan it, it'll take you directly to our link. So again, thank you so much to all of you, and thank you to our speakers. Have a great day.